cancer background epidemiology, there are 80,000 cases a year. Average age is 73. The male to female ratio is 3 to 1. The risk factors for bladder cancer are smoking. This contributes to 50% of bladder tumors. Additional risk factors include chronic irritation, such as what one would see with a Foley, chemical exposure, such as aniline dyes, prior radiation, and schistosomiasis. Pathology, 93% of these are urothelial, formerly known as transitional cell. 5% are squamous cell from chronic irritation or schistosomiasis. 1 to 2% are adenocarcinoma, usually from the urachus. A smaller percentage than that are small cell tumors or sarcomas, which are treated as per those sites. Note, non-urothelial histologies are treated the same way but have a far worse prognosis. Urachal carcinoma, the urachus, which is usually the dome, requires complete removal of the urachus. It is better prognosis than non-urachal adenocarcinoma. On initial diagnosis, 70 to 75% are superficial, non-muscle invasive bladder cancers. 20 to 25% are muscle invasive, and then 5% are metastatic. The trigone is the triangular region where the ureters enter the bladder and the urethra exits. It's the most common site of bladder cancers. Surgery consists of radical cystectomy. For a male, this usually involves removal of the bladder, the prostate, the seminal vesicles, the vas deferens, and the proximal urethra. For a female, this usually involves removal of the bladder, the urethra, with a TAH-BSO, and the anterior vaginal wall, i.e. an anterior exenteration. Radical cystectomy typically includes bilateral pelvic lymph nodes, which include the common iliacs, internal iliacs, external iliacs, and obturator lymph nodes. An incontinent diversion, ureters to ileal loop to skin to urostomy bag. Continent diversion, 80% continence rate. Ureters to an ileal loop, which then serves as a collecting bag. Then to skin, then to stoma, which is catheterized. Or you could have a neobladder with a Koch, Indiana, Miami pouch. Koch, Indiana, or Miami pouch. This is detubularized intestine to the urethra, allows volitional voiding. H&P, so workup, H&P, history, ask about gross hematuria, dysuria, urinary obstruction, smoking history, and pelvic pain. For women, do a pelvic exam. For men, do a penile and testicular exam. Also do a digital rectal exam. Pathology, you want office cystoscopy as well as urinalysis with urine cytology. This has high specificity but low sensitivity. Labs get CBC, CMP, ALK-Phos. Once the diagnosis of bladder cancer is made, you want a CT abdomen pelvis. If muscularis mucosa invasive, you can consider just pelvic imaging and non-invasive disease. CT chest if muscle invasive. Image the upper tract with the CT urogram. You can get an MR urogram if they have poor renal function. This is because 5% of patients will have synchronous upper tract lesions. Get a bone scan if there's increased alkaline phosphatase or if the patient has bony symptoms. Consider pelvic MRI. Primary evaluation, surgical treatment. EUA with female gynecologic exam. Cystoscopy with bladder mapping. Biopsy any masses that are apparent. TURBT with mapping biopsies. For early stage disease diagnosed on TURBT, repeat TURBT has benefit. Biopsy should include the bladder muscle wall, meaning the detrusor muscle and the perivesical fat. On subsequent pathology, muscle should be present, or if the muscle is present and or involved. You should also see some perivesical tissue. If there's no muscle, you should repeat the TURBT. Staging, 5-year overall survival. T-stage, TA is non-invasive papillary cancer. TIS is carcinoma in situ or flat. T1 invades the subepithelial connective tissue, i.e. through the lamina propria. T2 invades into the muscularis propria, meaning this is muscle invasive bladder cancer. T2A is superficial, meaning it invades the inner one half. T2B is deep, invading the outer one half. This is not accurately determined clinically. T3 invades the perivesical tissue. T3A is microscopic. T3B is macroscopic, i.e. extravesicular mass. T4 invades adjacent organs. T4A invades the prostate, the seminal vesicles, the uterus, or the vagina. T4B invades the pelvic or abdominal side wall. Again, T-staging, TA, non-invasive papillary, TIS, carcinoma in situ flat, T1, subepithelial connective tissue, T2 invades the muscularis propria, T2A is superficial, inner 1/2. T2B is deep, outer 1/2 muscularis propria invasion. T3 is perivesical tissue invasion. T3A is microscopic perivesical tissue invasion. T3B is macroscopic perivesical tissue invasion. T4, adjacent organ invasion. T4A, prostate, seminal vesicle, uterus or vagina. T4B, pelvic or abdominal sidewall. Nodal staging. N1 is a single pelvic lymph node. Pelvic is a perivesical lymph node that is below the common iliacs. N2 is multiple pelvic lymph nodes. Again, pelvic lymph nodes are those that are below the common iliacs. N3 would be common iliac lymph node. M1A are lymph nodes beyond the common iliacs. So, for example, a periaortic node. M1B are non-nodal metastases. Overall stage grouping, T1 tumors are stage 1. T2 tumors are stage 2. T3, T4A, or N1 is stage group 3. N1 is stage group 3A. T4B, N2 or plus, or M1 are all stage 4. The ideal BCT candidate has a T2 to T3 tumor, unifocal disease that's less than 5 centimeters in size, no extensive carcinoma in situ, no hydronephrosis, good bladder capacity, a visibly complete TURBT, good renal function to give cisplatin, and urothelial histology. Contraindications to bladder conservation therapy include hydronephrosis, incapable of having a maximum TURBT, poor renal function that doesn't allow for chemo, extensive CIS, or poor bladder function. Note that lymph nodes are present in 20 to 40% at diagnosis, 70% are perivesicular, 65% external iliac, internal iliac, and 15%. Any node-positive bladder cancer automatically should be stage 3 or greater. Management for non-invasive, so CTA, CTIS, or T1, there's about a 50% chance of recurrence after BCG. All these get initial TURBT. For a TA, low grade, it's observation after that. For a TA high grade, you get BCG. For a TIS, it's also BCG. For a CT1, low and high grade tumor, repeat the TURBT and then you do BCG. You can also jump to surgery if you have a CT1 tumor that is high grade or if there's residual disease on repeat TURBT. Intravesicular chemotherapy, this is most commonly BCG, just given 3 to 4 weeks after TURBT. You give 50 milligrams every 1 week times 6 cycles, so given for 6 weeks. Sometimes mitomycin is given. This is a weekly instillation for 6 weeks, then maintenance every 3 months. Follow with every 3 month cystoscopies, and if there's residual or recurrent disease, then you can do another round of induction BCG or go to cystectomy. If the patient is medically not a cystectomy candidate, you can do bladder conservation therapy. For muscle invasive disease, which is CT2 to T4A N0, option 1 would be neoadjuvant gemcitabine, 1,000 milligrams per meter squared, and cisplatin, 70 milligrams per meter squared, every 21 days times 4 cycles, followed by radical cystectomy with lymph node dissection. Adjuvant chemotherapy can be given if you have a PT3 to T4 tumor or node positive, but only if neoadjuvant chemotherapy was not given. You have the exact same regimen for neoadjuvant and adjuvant chemotherapy. Again, gemcitabine 1,000, cis 70 every 21 days times 4 cycles. You can consider adjuvant radiation for these indications, but probably shouldn't say that on boards. Overall survival at 10 years, 5% is increased with neoadjuvant cis-based chemotherapy prior to surgery. This is based on the SWOG 8710 meta-analysis. Your second option would be bladder preservation, but this is for the best players only. Again, unifocal tumor less than 5 centimeters, status post TURBT completely, CT2 to 3, CN0, good bladder function, no hydronephrosis, no CIS, no inflammatory bowel disease, no prior radiation. Complete TURBT is the most important and prognostic factor here. Per Astro 22 refresher, you can do up to T4 tumors. Hydro is not an absolute contraindication, but patients are at a high risk for failure. The treatment for this is maximum TURBT followed by chemo-RT to 40 to 45 gray. Repeat cystoscopy if complete response boosts to 64 gray. Chemotherapy here, you can do concurrent cisplatin, 15 milligrams per meter squared, days 1 to 3, 8 to 10, 15 to 17, with concurrent 5-FU, 400 milligrams per meter squared, again, days 1 to 3, but in this case, 15 to 17, so you leave out the 8 to 10. You could also do cisplatin paclitaxel. If you can't do cis, don't substitute carboplatin for cis. It doesn't work. Your alternatives are 5-FU and mitomycin C, 500 milligrams for 5-FU, days 1 to 3, 16 to 20, and mitomycin C, 12 milligrams per meter squared on day 1. You can also do gemcitabine alone, 27 milligrams per meter squared per Cohen RTOG 0712. Chemo improves local control by 10 to 15%. It improves bladder preservation and disease-free survival. There's no role for neoadjuvant chemo in bladder preservation per RTOG 8903. Radiation, you don't have to cover the nodes. If you do, then they suggest 45 gray to the internal and external iliacs, obturator, perivesical, sacral, and presacral nodes. MGH approach is to do chemo RT to 40 gray, then they do repeat cystoscopy and biopsy 3 weeks after starting radiation. If there's a partial response, then they proceed to cystectomy. If there's a complete response, then they complete the course to 64.8 gray. At Penn, they do whole course without evaluation, 64.8 gray to the whole bladder. Then they re-eval with CT, chest, abdomen, pelvis, and cystoscopy in 2 to 3 months. If there's a partial response, they do a salvage cystectomy. The downside to that approach is the dose to the bowel for the conduit that's used after salvage cystectomy is higher. Option 3 would be neoadjuvant gemcitabine cisplatin times 4 cycles with partial cystectomy if you have a unifocal T2 tumor without CIS or trigon involvement. If neoadjuvant chemo is not given, then adjuvant chemo again for PT3 to T4 or N-positive disease. For T4B or N-positive, definitive concurrent chemo RT, 45 gray plus 19.8 gray, 64.8 gray, cisplatin 100 every 3 weeks, or 5-FU mitomycin C if low or moderate renal function. Consider 36 and 6 as a palliative approach if they cannot tolerate concurrent chemo RT per the hybrid study. Medically inoperable, get definitive chemo RT or systemic therapy alone. Recurrent disease after cystectomy can get chemo RADS. Recurrence after bladder preservation, superficial 20%, TURBT and BCG. If no response, then radical cystectomy. Invasive 10 to 20% do a radical cystectomy. Evidence here, BCG has survival advantage over TURBT alone and decreases local recurrence. Overall survival at 10 years, 5% increase with neoadjuvant cis-based chemo prior to surgery per the SWOG 8710 meta-analysis. Adjuvant chemo has survival benefit for PT3 to T4 and positive weaker evidence. Data, neoadjuvant chemo prior to conservation, RTOG 8903, Shipley, JCO 1998. This is 123 T2 to T4A tumors. They got MCV times 2, then 39.6 gray to the pelvis plus cisplatin, then cystoscopy versus 39.6 gray plus cisplatin, then cystoscopy. They had complete response on cystoscopy, then you boost 64.8 gray and additional concurrent cystos, otherwise cystectomy. 5-year overall survival was 49% on both arms. Clinical complete response unchanged. 5-year overall survival with functioning bladder was 38%. Bottom line from RTOG 8903 is that neoadjuvant MCV prior to bladder preservation did not improve any outcomes. Bladder preservation, MGH, Shipley, Urology 2005, 190 T2 to T4A. This was a pooled analysis of 5 prospective trials. TURBT, then chemo RT to 64 to 65 gray of complete response after 40 gray or medically unfit for cystectomy. 5-year overall survival was 54%. 10-year overall survival 36%. Bladder preservation 40% overall, 70% achieved complete response. Bladder preservation results in favorable outcomes. RTOG Efstathiou Mac JCO 2014 meta-analysis of muscle-invasive bladder cancer. In 6 RTOG studies, T2 to T4A, technically tox outcomes for 4 trials, control outcomes 6 trials. Complete response 69%, 5-year intact bladder 80%, 5-year overall survival 57%, 10-year overall survival 36%. Late grade 3 tox, 6% GU, 2% GI, no grade 4 tox. Bottom line, bladder preservation results in favorable outcomes. Question of bladder volume, concurrent chemo, BC 2001, James 2021. This is 219 and 360 T2 to T4A and 0 2x2 randomization, either standard volume RT versus reduced high-dose volume RT, RHD VRT. Then randomized to concurrent 5-FU mitomycin C versus no chemo. Chemo was 5-FU 500 continuous infusion during weeks 1 and 4, and mitomycin C 12 IV day 1. Radiation was either 55 and 20 fractions or 64 gray and 32 fractions. Full dose was delivered to the tumor and 80% of the dose delivered to the uninvolved bladder with concomitant boost. Increased disease-free survival, local regional control with chemo-RT, no difference in overall survival, and outcomes comparable to best surgical series. BC 2001, HUD-ART, standard whole bladder, meaning bladder and extravesical tumor plus 1.5 centimeters versus reduced high-dose volume RT. PTV1 same, treated 80% of the dose. PTV2 is GTV plus 2 centimeters as above. No difference in 2-year LRFS or late toxicity with reduced high-dose volume RT. BC 2001 and BCON MA, Chowdhury, Lancet, Oncology 2021, meta-analysis of local control, overall survival and tox in these trials to assess non-inferiority of 55 and 20 versus 64 and 32. Results: 55 gray had lower risk of invasive local regional recurrence than 64. No overall survival difference. Technique: CT simulation, supine, immobilized with Vaclock, empty bladder, also full bladder for boost if you're doing partial bladder treatment. If you're doing a boost to the full bladder, you only need empty bladder. Start within 8 weeks of maximal TURBT. Dose: whole pelvis to 45 to 50.4 gray and 25 to 28 fractions. Then bladder tumor boost to 60 to 65 gray. You can do 64 gray and 32 fractions to the whole bladder or 55 gray and 20 fractions to the whole bladder. Volumes: whole pelvis, CTV fields are bladder, prostate, internal and external iliacs, obturator, or presacral nodes. Lymph node PTVs, lymph node CTV plus 7 millimeters. Bladder PTVs, the bladder plus 1.5 centimeters with prostatic urethra in men. Bladder boost target can include the initial TURBT area or a known bladder tumor with 2 centimeter margins. If you don't know, then boost the whole bladder. Whole pelvic fields, APPA 70% and laterals 30%. Superior borders, mid-SI joint, S2, S3, spares the ilium. Inferior borders, bottom of the obturator foramen are 2 centimeters below the tumor. Lateral is 2 centimeters on the pelvic brim, block the femoral heads. Lateral is same sup inf, 2 centimeter anterior posterior margin on bladder with blocks for rectum, small bowel. Setup: daily KV and cone beam CT. Constraints: PTV 95% of the dose gets 95% of the volume gets 95% of the dose. Rectum max 64.8. V55 less than 10%. V40 less than 40%. Large bowel, V60 less than 20%. Small bowel max 64.8. V60 less than 10 cc's. V45 less than 125 cc's. Femoral heads, V50 less than 10. V45 less than 20. Palliative regimen: 55 and 20 fractions or 50 and 20. Can consider with chemo, 36 and 6 if patient cannot tolerate chemo-RT. Toxicity follow-up outcomes: the 5-year overall survival with cystectomy or bladder preservation for TA tumors is 95%, for T1 tumors is 70%, for T2 tumors is 60%, T3 is 40%, 40% up to T4. 68% of patients have a functioning bladder at 5 years, 40 to 50% are alive with a functioning bladder, 1/3 requires cystectomy. 5-year overall survival is 50%, 10-year overall survival is 30%. 10-year bladder intact disease-free survival rate after chemo-RT is 40%. 75% have a complete response. 50 to 70% of survivors have a functioning bladder. 5-year disease-specific survival is 60%. 30% will require salvage cystectomy. Only 5 to 10% require cystectomy secondary to radiation complications. Node-positive disease, 5-year overall survival is 30%. Positive METs, median survival is 6 to 12 months. Bowman failure patterns for muscle-invasive bladder cancer, PT3+, status post radical cystectomy, iliac and obturator nodes for negative margin, radical cystectomy, cystectomy bed, and presacral for positive margin radical cystectomy. Follow-up per NCCN, non-invasive, cystoscopy with cytology every 3 months times 1 year, then every 6 to 12 months. Image the upper tract every 1 to 2 years. For muscle-invasive disease, cysto, CT, chest, abdomen, pelvis, upper tract imaging every 3 to 6 months times 2 years, then annually.